Hello, and a very warm welcome to all of you. Thank you for joining us and supporting Doc Plexus in our journey of 9 glorious years celebration last month. Welcome to the Doc Plexus Global Diabetes Summit 2022, which is a 3-day clinical discourse organized from 12th to 14th of November to discuss and tackle the largest and most affecting disease of the world. Discussing topics around access to global diabetes care and education. You all must be aware that 463 million adults were diabetic in 2019. The number of people with diabetes is expected to rise to 578 million by 2030. Currently, India has 77 million people affected with diabetes, which makes it the second most affected country in the world after China. The International Diabetes Federation has projected the number to grow to 134 million by 2045. Out of the 77 million diabetic patients, 68% are being treated with oral hypoglycemic agents, 25% are being dependent on insulin, 7% are being treated with injectable GLP-1. Among children, according to a study published in the Indian Journal of Endocrinology and Metabolism, it is estimated that India is home to about 97,700 children with type 1 diabetes mellitus. So we can make an assumption about the plethora of issues that the world is facing currently due to diabetes. Hence, Doc Plexus brings to you the Global Diabetes Summit, which is spread across 3 days. For day 1, we would be addressing the diabetes linked to cancer and surgeries for diabetes treatment. Day 2, we would be presenting to you a 1-credit ACME webinar on A to Z of diabetes prevention, management, and advances. Please note that the registrations for ACME are still open. Day 3 will be experts roundtable discussion with renowned international and national panelists on the latest developments in management of diabetes, along with other panel for addressing the holistic management of diabetes. Today's session is focused on diabetes and cancer, link and challenges in diabetes management. Cancer treatments like steroids, surgical resection of the affected part, chemotherapy drugs, and the targeted therapies can predispose cancer patients to diabetes. Diabetes can also develop as a side effect of many of these interventions. High blood sugar can cause dehydration, which increases the risk of side effects following the cancer treatment. Therefore, managing high blood glucose levels is crucial, and one should be done vigilantly, as it can interfere with the disease process of cancer and the other related health issues. And to explain more on this, we have with us today Dr. Apar Kishor Ganti, Dr. Sahela Sheikh, Dr. Chetan Deshmukh, Dr. Anish Behel. The session would be moderated by Dr. Vaishali Deshmukh. Dr. Vaishali Deshmukh is consultant endocrinologist and head at Dinanath Mangeshkar Hospital and Research Center and at Deshmukh Clinic and Research Center, Pune. She is also an assistant professor at Sassoon General Hospital and BJMC, Pune. She is also the founder and secretary of the NGO Sphere. She has numerous achievements to her credit, such as Profession Women Award, Kranti Surya Pratishthan, Adarsh Mahila Puraskar, Jeevan Gaurav Puraskar. Dr. Deshmukh has multiple interests in mild body medicine, neurobehavioral endocrinology, endocrinology in women, and has numerous publications to her credit. So without any further ado, let's commence the session. Dr. Deshmukh, over to you.
Hello, everyone. A warm welcome to all of you on this eve of World Diabetes Day. We are here today for an important discussion on an important topic of diabetes and cancer. So we know that diabetes is a prevalent disease and so is cancer. And there is a close association with both these chronic diseases. So we all know that diabetes has a very high risk of getting cancer, nearly to the tune of 20 to 30%. And similarly, patients with cancer are prone to development of diabetes because of various causes. Now, on this eve of this World Diabetes Day, the theme is to educate, to protect the tomorrow. And tomorrow, we know that we are here to prevent many of the diseases in diabetic patients, of which cancer is an important disease, which has a very high mortality. So today we will be having a session on this important topic. And we will begin our session with our talk on how the anti-cancer agents are known to produce diabetes. So we will start with our first talk with the talk given by Dr. Apar Kishor Ganti. So before we go to the topic per se, I would like to introduce him. I will share his CV slide. So I have today four eminent speakers with me. So one is Dr. Apar Kishor Ganti, who will be giving us the first talk on diabetes as a side effect of cancer chemotherapy. Dr. Apar Kishor Ganti is a physician scientist. We are proud to have he being originated from Pune. So he is actively involved in medical practice and clinical research. He specializes in care of patients with head and neck cancer at Omaha Veterans Affairs Medical Center and the University of Nebraska Medical Center. He is the Dr. D. Leon UNMC Research Fund Chair in Medical and Internal Medicine at the University of Nebraska Medical Center. He serves as the Associate Director of the Clinical Research at the UNMC Fred and Pamela Buffet Cancer Center. In addition, he is a member of Respiratory Committee of the Alliance of Clinical Trials in Oncology. He is the chair of the Small Cell Lung Cancer Committee of National Comprehensive Cancer Network. He is a member of the VA Precision Oncology Program Advisory Committee, the Veterans Affairs Clinical Science Research and Development Centralized Data Monitoring Committee. He has special interest in development of novel treatment approaches for patients who are not candidates for standard therapies, and his lab focuses on evaluating new pathways in head and neck cancer and in lung cancer. He is also significantly mentoring and has mentored many medical students, residents, and fellows, junior faculty in research projects, and he is presented at national and international meetings and published in several peer-reviewed journals. So welcome, Dr. Apar, and over to you for your first talk. Along with Dr. Apar, we have three eminent panelists whom I will be introducing at the time of the panel discussion. So meanwhile, I welcome Dr. Shaila Sheikh Madam, Dr. Chetan Deshmukh sir, and Dr. Anish Behel on this panel. So over to you, Dr. Apar.
Hello, everyone. First, I would like to thank the organizers for giving me this opportunity to talk on cancer therapy-induced diabetes. These are my disclosures. Here's the outline of what I propose to speak in the next 20 minutes or so. I will first talk about the relationship between cancer and diabetes, and then I will talk about anti-cancer agents responsible for causing hyperglycemia in cancer patients. The agents or the classes of agents that I will talk about include glucocorticoids, PI3 kinase inhibitors, and finally, immune checkpoint inhibitors. As you all know, diabetes can be a risk factor for cancer. And as you can see in this graph on the left here, diabetes alone accounts for over 300,000 cases of cancer in the world. These are cancers attributable to diabetes. And if you include high BMI, which is commonly associated with diabetes, the combined number of cancers attributable to diabetes and high BMI worldwide are approximately 800,000. And if you look at different parts of the world, the incidence of cancer attributable to diabetes seems to be different. If you look at Mongolia and China, for example, the population attributable fraction ranges from between 4 to 8%. In places like India and Australia, it's lower at about 1%. Sub-Saharan Africa, as you can see here, seems to have the lowest population attributable fraction to diabetes. But I suspect the main reason for this is a lack of reporting rather than a true lack of diabetes. When we consider cancer and diabetes, I like to think about it as the Bermuda Triangle. As we've just discussed, diabetes can be a risk factor for cancer in many circumstances. And then cancer treatment toxicity can lead to diabetes, as we will talk about in the next part of my talk. And then cancer itself of the pancreas and certain other organs can lead to diabetes just because of the involvement of the pancreas. When we talk about cancer treatment-induced diabetes, three major classes of drugs come to mind. Glucocorticoids are the most obvious ones. They have been in use for a long time. But some of the newer agents that have been shown to induce diabetes or hyperglycemia include the PI3 kinase inhibitors and more recently, the immune checkpoint inhibitors. Let's first talk about glucocorticoid-induced hyperglycemia. Glucocorticoid-induced hyperglycemia is a common cause of diabetes. The odds of developing diabetes after glucocorticoids range from anywhere between 1.36 and 2.31. The rates of hyperglycemia vary by the glucocorticoid indication, for anywhere from 2% to 50%. A common example is dexamethasone, which is often used as an antiemetic against highly emetogenic chemotherapy agents. It is given for about 3 days in every cycle. And studies have shown that the incidence of diabetes with 3 days of dexamethasone given as an antiemetic is approximately 22%. Not surprisingly, higher doses of glucocorticoids increase the odds of requiring antihyperglycemic agents. Other risk factors in glucocorticoid-induced hyperglycemia include the duration of treatment, again, not surprising, increased age, increased weight, a prior history of glucose intolerance, and a family history of diabetes mellitus. This cartoon here shows the mechanisms by which glucocorticoids induce hyperglycemia. As you all know, glucocorticoids can increase glucose production in the liver by increasing gluconeogenesis and decreasing insulin sensitivity. In the pancreas, pro-apoptotic stimuli associated with glucocorticoids can lead to progressive beta cell failure, leading to a decrease in insulin production and an increase in glucagon production. In the intestines, there is impaired effects of incretin due to glucocorticoids. There is decreased capillary recruitment. In the muscle, there is decreased glucose uptake and increased proteolysis. And finally, in the adipose tissue, there is lipolysis due to glucocorticoids, which results in decreased insulin sensitivity, increased levels of resistin and leptin, and decreased levels of adiponectin, all of which result in increased blood glucose levels. Here's another cartoon which shows a similar mechanism of action. They also seem to act on the brain via the hypothalamic pituitary axis, and that leads to increased secretion of neuropeptide Y, which is seen in the sympathetic neurons, and this leads to hyperinsulinemia, hyperphagia, and weight gain. Even though there is hyperinsulinemia, hyperphagia and weight gain lead to increased insulin resistance. We talked about the effects of glucocorticoids on the liver, where there is increased gluconeogenesis, increased lipogenesis, increased triglycerides, and hepatic steatosis, all of which lead to hyperglycemia. In the muscle, like I mentioned earlier, there's decreased glucose uptake, increased proteolysis, increased beta oxidation and lipolysis, increased triglycerides, and intramyocellular fat deposit, again, all of which lead to hyperglycemia. In the white adipose tissue, there is the increased glucose uptake, but there is also lipolysis, pre-adipocyte differentiation, and adipogenesis, leading to visceral fat deposits, eventually leading to increased free fatty acid secretion. Increased free fatty acids then cause increased insulin resistance, and the net result of this entire chain of events is increased blood sugar levels. Here's one approach to managing hyperglycemia induced by glucocorticoids. One of my colleagues, Dr. Anupam Kotwal, developed this algorithm working with his colleagues at Mass General Hospital in Boston. So if a patient has a prior history of diabetes but is not on insulin, if the glucose is greater than 140 milligrams per deciliter fasting or more than 200 milligrams per deciliter random, and the patient is adherent to diabetic medications, then you look at the type of steroids that the patient is on. If the patient is on more than 2 milligrams of dexamethasone daily or more than 10 milligrams of prednisone daily, start NPH insulin prior to the morning meal. at a dose of approximately 0.15 units per kilogram, and then titrate to get a pre-dinner glucose level of less than 200. If the patient is on intermittent glucocorticoids, which is often the case, if the patient's on prednisone or methylprednisone, dose the insulin on every day the glucocorticoid is given. For dexamethasone, dose the insulin on every day the dexamethasone is given, but also for 2 additional days. If that does not work, then the same algorithm with NPH insulin as I discussed earlier. If NPH is not effective, or if the patient does not want to take NPH, you can use premixed insulin prior to the morning meal, start slowly and titrate up. If the patient does not have a history of diabetes, but has new glucocorticoid-induced diabetes, and the glucose is more than 140 milligrams per deciliter fasting, or more than 200 milligrams per deciliter on a random test, not on diabetes medication, then start diet and exercise counseling, and metformin unless there are specific contraindications to metformin. If there is persistent hyperglycemia and the patient is on daily glucocorticoids of 2 milligrams or greater of dexamethasone or 10 milligrams or greater of prednisone, then you could start glipizide at a lower dose and then titrate up to response. Other options include ripaglinide or nateglinide. Again, if the patient is on intermittent dose glucocorticoids, you could dose the medications on the days that the glucocorticoid is given, or in the case of dexamethasone, on that day plus 2 additional days. If oral and hypoglycemic agents are not effective and the glucose is still greater than 200 before dinner, then start using NPH prior to the morning meal at a dose of around 0.1 units per kilogram and then titrate upwards. Moving on to PI3 kinase inhibitors, these are a new class of anti-cancer drugs which act on the PI3 kinase and block its downstream signaling. PI3 kinase normally stimulates the AKT pathway, which then stimulates the mTOR pathway, leading to cell survival. These drugs act on various components of this cascade and thereby blocking both AKT and mTOR. There are 3 PI3 kinase inhibitors currently approved by the US FDA in various hematologic malignancies. Copanlisib is approved for follicular lymphoma. Duvelisib is approved for chronic lymphocytic leukemia and small lymphocytic leukemia and follicular lymphoma. Idelalisib is approved for CLL, follicular non-Hodgkin's lymphoma, and small lymphocytic lymphoma. This is the mechanism of action. As you can see here, PI3 kinase is activated by binding of a ligand to the receptor tyrosine kinase, and that activates this entire cascade, which acts in multiple different mechanisms. You have the RAS, RAF, MEK, ERK pathway, which is responsible for growth differentiation. And also, this pathway inhibits TSC and mTOR. Normally, this pathway leads to a slowing of cell growth. But when this pathway is inhibited by ERK, it stimulates protein synthesis and cell growth, thereby leading to cellular proliferation. Also, PI3 kinase inhibitors act on the AKT pathway, which then promotes cell survival, proliferation, and metabolism. Now, how do PI3 kinase inhibitors induce hyperglycemia? When insulin binds to the insulin receptor, it stimulates PI3 kinase. Obviously, when this PI3 kinase is blocked, the effects of insulin downstream are abrogated, leading to increased glucose levels in the blood. There is a blockade of glucose transport, decreased glycogen synthesis, there's decreased glycolysis, there's decreased lipogenesis and protein synthesis, and the glycolytic genes go down in response to blockade of PI3 kinase. The net result of this is that there is increased blood sugar level, decreased insulin production and activity, and increased glucagon levels. The most common severe or life-threatening adverse effect of PI3 kinase inhibitors is hyperglycemia, with reports of incidence between 50 and 64% of patients. Risk factors for PI3 kinase inhibitors induced hyperglycemia is age less than 65, pre-existing type 2 diabetes, a fasting plasma glucose of greater than 153 milligrams per deciliter at baseline, BMI of 25 kilograms per meter squared, and an Asian race. How do you manage these? Before starting a PI3 kinase inhibitor, it is recommended that every patient has a fasting plasma glucose and a hemoglobin A1C. Once you initiate PI3 kinase inhibitors, regular monitoring of glucose levels. If the patient has mild hyperglycemia, meaning a fasting plasma glucose of 140 to 159 milligrams per deciliter, or a random glucose of less than 200, repeat the fasting plasma glucose, repeat an A1C, continue the PI3 kinase inhibitors, and routine follow-up. If the patient has moderate, severe, or life-threatening hyperglycemia, then it is important to evaluate for diabetic ketoacidosis and hyperosmolar syndrome. If the patient does not have DKA or HHS, then lifestyle modification, glucometer education, and glucose monitoring is mandatory. If the goal of treatment should be to get a plasma glucose level of less than 160 and a random glucose of less than 200. If the patient has moderate hyperglycemia, meaning a fasting plasma glucose of 160 to 249 milligrams per deciliter, or a random plasma glucose of 200 to 299 milligrams per deciliter, the recommendation is to start metformin, continue the current dose of alpelisib, but reduce the dose if the glucose remains greater than 160. If the patient is on copanlisib, stop until the fasting glucose gets to less than 160. Now, if the patient has moderate or severe hyperglycemia, which is a fasting plasma glucose of 250 to 499 milligrams per deciliter, or a random glucose of 300 to 599 milligrams per deciliter, start metformin, could consider starting another agent, and hold the drug till the fasting plasma glucose gets to less than 160. If the patient has life-threatening hyperglycemia but does not have DKA, then the recommendations are to admit the patient, start intravenous fluids, stop the PI3 kinase inhibitor, and manage with insulin, and discharge the patient home on a basal and bolus insulin. If the patient has diabetic ketoacidosis or hyperosmolar syndrome with a serum osmolarity of greater than 320 and a random plasma glucose of more than 600, stop the drug, admit the patient, manage with IV fluids and insulin. If the PI3 kinase inhibitor is stopped, then stop all anti-hypoglycemia causing agents like insulin or sulfonylureas. Continue other agents like metformin for about 2 weeks till the glucose improves, and then stop all drugs once the blood glucose levels normalize. Immunotherapy has revolutionized the treatment of cancer. Immunotherapy agents are used in multiple different malignancies, and this is the basic mechanism of action of these drugs. When cancer cells die, they release cancer antigens. These antigens are presented to the antigen-presenting cells, which then present these antigens to the T cells and activate the T cells. These activated T cells are trafficked into the tumors. These are the cytotoxic T lymphocytes, which then infiltrate the tumors, recognize the cancer cells, kill them, and this whole process repeats over and over again. There are multiple different proteins on the T cell which serve as either activating receptors of the immune system or inhibitory receptors. To date, all of the anti-immunotherapy agents that are used against cancer are inhibitors of the inhibitory receptors. The common ones that are currently used in practice are CTLA4 inhibitors like ipilimumab or tremelimumab, PD1, PDL1 inhibitors like pembrolizumab, nivolumab, durvalumab, cemiplimab, and LAG3 inhibitor relatlimab. Inhibition of these inhibitory receptors leads to T cell stimulation. As you all may know, the Nobel Prize in Physiology of Medicine for 2018 was awarded jointly to James Allison and Tasuku Honjo for their discovery of cancer therapy by inhibition of negative immune regulation. James Allison worked on CTLA4, and Tasuku Honjo worked on the PD-1, PD-L1 pathway. How do these drugs work? As I mentioned earlier, PD-1 and CTLA4 are inhibitory receptors on the on the T cells. PD-1 binds to PD-L1. PD-L1 is often seen on tumor cells or antigen-presenting cells. Similarly, CTLA4 binds to B7 on the tumor cell or the antigen-presenting cells. When these bonds are intact, that leads to an energy of the T cells, and the immune system against cancer is suppressed. But when you block these bonds by using either an anti-PD-1 or an anti-PD-L1 drug, or in the case of CTLA4, an anti-CTLA4 drug, these bonds between PD-1, PD-L1, and CTLA4-B7 are broken. The T cell is activated, and then activated T cells stimulate the cytotoxic T cells and therefore kill the cancer cells. Now, immune checkpoint inhibitor-related hyperglycemia could be due to multiple different mechanisms. I will not talk about those patients with pre-existing type 2 diabetes or steroid-induced hyperglycemia. We've already talked about this, but focus more on the autoimmune causes. The most common one is checkpoint inhibitor-associated autoimmune diabetes mellitus, where you have increased C-peptide and autoantibody levels. Immune checkpoint inhibitor-related pancreatitis, where lipase levels are extremely high. And then immune checkpoint inhibitor-related lipodystrophy, which is mostly based on clinical exam, high triglyceride levels, and a biopsy, which shows the dystrophy in the fat cells. It is important to distinguish checkpoint inhibitor-induced diabetes from type 1 diabetes, as both are associated with absent insulin. Checkpoint inhibitor-induced diabetes usually presents with diabetic ketoacidosis at presentation, with over 2/3 of patients, that is the presenting finding. In contrast, in type 1 diabetes, the proportion of patients presenting with DKA is only about 6%. Checkpoint inhibitor-associated diabetes has a fulminant course with overt insulin deficiency, whereas type 1 diabetes, on the other hand, is a gradual worsening of blood sugar levels. You have anti-GAD antibodies in checkpoint inhibitor-associated diabetes compared to islet autoantibodies in type 1 diabetes. When you look at the genetic predisposition, only 2/3 of patients who have checkpoint inhibitor-associated diabetes have the susceptibility haplotype compared to 90% of type 1 diabetes patients. Interestingly, about 10% of patients who develop checkpoint inhibitor-associated diabetes have a protective haplotype. Checkpoint inhibitor-associated diabetes also involves the exocrine pancreas frequently, with elevated pancreatic enzymes seen in over half of the patients. In contrast, type 1 diabetes, there are decreased enzyme levels, and often the exocrine pancreas are not affected at all. This is the mechanism of action of checkpoint inhibitor-associated diabetes. This is the beta cell. There is some form of environmental exposure, which leads to the development of autoreactive T cells against the islet cells. These can attack the B cells, but similar to what we see in cancer, the PD-1 present on the cytotoxic T cell binds to the PD-L1 receptor on the B cells, and this B cell expression of PD-L1 downregulates the cytotoxic T cell, and therefore the B cell function is preserved. However, when you have an anti-PD-L1 or an anti-PD-1 drug, that breaks this particular bond, resulting in activation of the cytotoxic T cell, resulting in B cell destruction and a rapid development of insulin deficiency. ICI-induced diabetes is relatively rare, occurring in 1 to 2% of individuals. It is almost exclusively seen with PD-1, PD-L1 inhibitors, and almost never with CTLA4 inhibitor monotherapy. Researchers at the Mayo Clinic analyzed their database of checkpoint inhibitor-treated individuals and found that 1% of patients developed new-onset insulin-dependent diabetes after treatment with a PD-1 inhibitor. They also saw some worsening of underlying type 2 diabetes. And interestingly, they found that patients who had underlying type 2 diabetes developed diabetic ketoacidosis less frequently. How do you manage checkpoint inhibitor associated diabetes mellitus? Before starting the drug, measure fasting plasma glucose and an A1C. If normal, then measure the same before every infusion and check a hemoglobin A1C every 3 months. If the patient has diabetes or prediabetes, optimize blood glucose prior to checkpoint inhibitor initiation. If the baseline evaluation is normal, the workup involves just a fasting plasma glucose level. If you find that the fasting plasma glucose level is greater than 126 or a random glucose is more than 200, or these levels are low but they have other features, or if the patient has difficult to control glucocorticoid-induced hypoglycemia, then check for type 1 diabetes antibodies. If the patient does not have DKA or HHS, continue the checkpoint inhibitor and start management as you would any patient with insulin deficient diabetes with basal insulin and rapid active corrective insulin. Follow up in 3 weeks or so. If the patient has a low risk of absolute insulin deficiency, meaning the C-peptide is preserved, the type 1 diabetes antibodies are negative, the dose of insulin required is small, then you could consider careful de-escalation of the insulin. If, on the other hand, the patient has a high risk for absolute insulin deficiency, meaning that the fasting plasma glucose is still high, C-peptide levels are low, there is glycemic variability, or if the diabetes antibodies are positive, then continue to a basal bolus insulin regimen. If the patient has a history of type 2 diabetes or prediabetes on an oral agent, monitor blood glucose levels. If the random is more than 200 and there is concern for DKA, or if the random sugar level is more than 250 and the patient has symptoms for hyperglycemia, evaluate for diabetic ketoacidosis and hyperosmolar syndrome with blood pH, basic metabolic panel, serum or urine ketones, serum osmolality. And again, if the patient does not have DKA or HHS, continue the checkpoint inhibitor and follow this algorithm. If, on the other hand, the patient has DKA, stop the checkpoint inhibitor, send the patient to the hospital, manage per the hospital protocol, and discharge on both basal or bolus insulin. Similarly, if the patient has a type 2 diabetes but requires intensification of insulin, have the patient check blood glucose more frequently, repeat fasting glucose, type 1 diabetes antibodies, hemoglobin C, and C-peptide more frequently. In conclusion, I hope I have convinced you that hyperglycemia is a relatively common manifestation associated with cancer chemotherapy. The most common class of drugs that cause hyperglycemia in cancer patients are glucocorticoids, PI3 kinase inhibitors, and immune checkpoint inhibitors. Life-threatening hyperglycemia, including DKA, while rare, can occur. It is important to monitor glucose and intervene early so as to prevent the complications. And I cannot stress upon you the importance of an interdisciplinary approach with a close collaboration between oncologists and endocrinologists while managing these patients. I thank you for your attention.
So thank you, Dr. Apar. That was an elaborate and a very extensive discussion on how oncologic drugs are known to produce cancer. Oncologic drugs are known to produce diabetes. So I think that's an important education that we are giving our audience, that we need to monitor for their blood glucose when they are on anti-cancer agents. So thank you so much for that discussion. So now we move on to the second part of the session, that is the panel discussion. The panel discussion is going to take over through an important topic of what are the cancer links with diabetes and what are the challenges in diabetes management. So we have three eminent faculty. First is Dr. Shaila Sheikh, madam. She is a DM in endocrinology and practicing as consultant endocrinologist at Prince Ali Khan Hospital, Saifi Hospital, and Wockhardt Hospital, Mumbai. She has been principal investigator in several clinical trials, nearly 35, and she's been member of Executive Committee of the Endocrine Society of India. She's the past treasurer of Endocrine Society of Maharashtra. She's been the member of Scientific Committee of the CAD. She has been awarded Top Docs of Mumbai by the Times of India Group from 2017 to 2022. She is the author of International Hajj and Diabetes Guidance and IDF DAR Guidelines 2021. She has published many papers, review articles, and she's been speakers at national and international forums. So welcome, madam.
Thanks, Vaishali. Thank you very much.
Then we have Dr. Chetan Deshmukh. He is a DM in medical oncology. He's the first DM medical oncologist in Pune from Tata Memorial Hospital. He's consultant medical oncologist at Dinanath Mangeshkar Hospital, Orchids Breast Health, Jahangir Hospital, and Ruby Hall Clinic, Pune. He's an honorary oncologist at Sassoon General Hospital. He's a former editor of American Cancer Society India Initiative. He's actively involved in clinical research for past 15 years and has been investigator in nearly 75 clinical trials. He is currently the president of the NGO Society for Prevention, Healthcare, Education and Research. So welcome, Dr. Chetan.
Thank you.
Then we have Dr. Anish Behel. He is a DM endocrinologist from Mysore. He is consultant endocrinologist at Apollo Sugars, Apollo BGS Hospitals, Mysore, and Wellness Super Speciality Center, Mysore. He's been a sought-out speaker at various CME and conferences at national and international level. He's been principal investigator in various clinical trials and has few publications to his credits. So welcome, Dr. Anish.
Thank you.
So we are going to talk about how diabetes links to cancer and what are the challenges that we come across. So my first question is to the oncologist. So what is the link between cancer and diabetes? Is there a link, and what is the link, and which cancers are common in diabetes?
There is definitely a link. Am I audible?
Yes, you are.
Excellent. Thank you. So there is definitely a link between diabetes and cancer. It was actually found out only recently that there was a research where people with chronic hyperglycemia develop DNA adducts. And as a result of these adducts, the DNA division is faulty and you develop faulty cells. And then they go into forming cancer into the body. So this link has been known, though there is a lot of work yet to be done, and which pathways affected and how to target it is not yet very well clear. We have been seeing a lot of patients with diabetes. A lot of our patients have diabetes. Initially, we thought that because diabetes is also common and cancer typically happens in the 5th or the 6th decade when most of the patients used to come with some kind of medical ailment. So we thought that there was only not a very clear-cut linkage, but this study has shown that there is some definite biochemical factor involved as well. For diabetics, it is known that these patients are more prone for carcinoma of colon, carcinoma of pancreas, carcinoma of breast and endometrium, probably because these patients also tend to be a little overweight and hypertensive. So probably some element of hyperesteronism also exists. And of course, urinary bladder carcinoma is also found to be more in diabetics compared to the other individuals. So there is definitely a link between diabetes and cancer.
Okay, so once we've said that the link is on the higher side, so Dr. Shaila, what challenges do you come across in cancer patients when you're dealing with diabetes in cancer patients?
Vaishali, first of all, thank you for making me a part of this fantastic initiative for education today for a better tomorrow. So thanks. And it's a very, very relevant question, Vaishali, because we do face a number of challenges as to when we are managing our diabetic patients with cancer. Just to address a small part of it, for example, when you are having a patient who's a diabetic patient who is giving oncology therapy, a number of medicines which are used in oncology cause hyperglycemia. For example, steroids is one of the medications which is used very commonly by oncologists. which can precipitate hyperglycemia in a patient who is not diagnosed with diabetes A. B, in a patient who's already having diabetes, it can further worsen hyperglycemia. C, in a patient who's not very well controlled, other than per se the oncology therapy as such, these patients also at an increased risk of infections, have a worse prognosis as far as surgery is concerned. So when a diabetic patient is having malignancy, along with a number of other factors which come into play in these patients. As far as, if I can answer just one part of the problem, that is as far as the steroid-induced diabetes is concerned, which I'm sure Anish will also talk about. Steroid-induced diabetes, Vaishali, is a little different from the routine diabetes that we see in clinical practice. I'm sure Chetan mainly uses once a day steroid. He must be using steroids in the morning to, most of prescriptions by my co-oncologists will be prednisolone in the morning, which is an intermediate acting steroid. And when you are asked to diagnose diabetes in these patients, what invariably happens as a clinician, you go and advise for a fasting and sometimes a postprandial, which is done generally after post-breakfast, and an HbA1c. Now, all the three parameters will not pick up diabetes in these patients, unfortunately. That's something which I would like to bring to the attention of this audience. Fasting, your patient may have a normal fasting in spite of having hyperglycemia the rest of the day, because by the time you've done the fasting, the effect of the steroid has more or less worn off. Because this is acute hyperglycemia, and HbA1c may not be very good in picking up these patients' diabetes, because it is an acute onset hyperglycemia. Your post-breakfast, again, your morning steroid, which Chetan has given, has not kicked in. The effect is going to be seen mainly by post-lunch and early dinner time. That's why you may not pick up hyperglycemia. So the best time to diagnose these patients would be by doing a post-lunch sugar, or maybe an early pre-dinner sugar, where you could actually diagnose these patients right. Then I'm sure we'll further go on with the further discussion.
Yeah, I think Shaila's made a very important point here, that it is not unlike other steroid-induced diabetes. You may not pick up unless you really monitor their postprandial. So I think in all our cancer patients henceforth, we need to do their postprandials also, not only their fasting labs. So that's an important take home for today. So what's your experience with management there are two scenarios, like you have patients on repeated chemotherapies and they keep on coming every 2 months or 3 months or every 3 weeks maybe, and they are on steroids at that particular moment of the chemotherapy. So how do you manage them in the IPD setting, and how does it really, I would like to ask this to Dr. Anish later, how does it differ in the OPD setting?
In the IPD setting, it differs that, when you're giving steroids to the patient, especially when you're giving high doses steroids, a lot of high dose steroids are used in an IPD setting along with chemo. So there may be a sudden surge of sugars. Secondly, as a result of the chemo, directly the patient has loss of appetite, nausea, a lot of vomiting. You are not sure what kind of meals your patient is going to consume. There's a general feeling of ill feeling. A lot of patients, to be very honest, when they come in for chemo, also are very stressed. That itself causes a lot of stress-induced hyperglycemia. I mean, no patient comes in for chemo in a very, very good state of mind. You're the best person to be talking about this. But the fact remains that a patient is not in the best mental state of mind also, which all contributes to hyperglycemia. The best way of managing these patients is with short-acting insulin when you're not very sure of their meal timings. The advantage of using short-acting analogs, I would prefer using short-acting analogs in these patients, because you can use them immediately before a meal if you're sure that your patient is going to have a proper meal, or you can also use it immediately after the meal, depending upon the calorie consumption that the patient has had. Or sometimes you can also use it up to 30 minutes post-meal. So in the case the patient has nausea and has vomited, you can just simply omit that dose of insulin. So in an IPD setup, I think the safest and the easiest way to manage your patients is with frequent monitoring with SMBG and short-acting insulin analogs according to their intake and depending upon the other parameters.
Yeah. So Dr. Anish, do you think that OPD management differs, or it is similar to what Shaila was saying?
First of all, Vaishali, let me thank you for this invitation. Let me start by saying that there is a little difference in the way we manage these patients on OPD basis. The first thing is that it depends on what kind of steroids are being used. For example, as Dr. Shaila rightly said, when you use steroids like prednisolone, the sugars would go up towards the later part of the evening. Now, sometimes they also use Dexona in these chemotherapeutic regimens. Now, Dexona has a very long half-life. So what happens is for up to almost 3 days, sometimes 2.5 to 3 days, the sugars would be on the higher side. So there, what we see is that when a patient takes chemotherapy cycles, as you say, once in 21 days, for those 3 or 4 days, the sugars would shoot up. So if somebody is a diabetic and on oral drugs or on insulin, those 3-4 days, the sugars would shoot up. So you would probably need a more intensive monitoring with a step up of dose. And the first day of chemo and the second day of chemo, the insulin dose requirements probably would be much higher. Now, what happens is in an inpatient setting, the patient is in the hospital. So the sugars are checked. Probably the nurse would, if the sugars are out of the range that you want, then the nurse would probably inform the doctor, and then you can adjust the dose of insulin. Now, when a patient has taken chemo and gone home, so you need to give them very clear instructions that maybe the first and the second day they may require a little higher dose, and probably from third day onwards they're going to go back to their original dose. So this is a challenge which probably is seen many a times. And if these cycles are more frequent, then invariably the HbA1c levels is going to go up also. And as all of us would agree that probably even in this setting, we may not aim for a very tight HbA1c level, but at least 7.5 is what we are aiming for most of these patients. So frequent chemotherapies, especially with long-acting agents, it's a challenge. Now, other than that, if the patient is a non-diabetic and the sugars have gone up only during a phase of chemotherapy, what's called a stress hypoglycemia or steroid-induced hypoglycemia. Now, these patients may have intermittent, they may come back to normal sugars between the regimens. So probably the best way of doing it is that every time they go for their chemotherapy, it's a good idea to check the sugars before the initiation of chemotherapy and maybe for 1 or 2 days post chemotherapy. And once they've finished the cycles of chemotherapy, if the patient is, I would say, not predisposed to get diabetes, for example, if the patient does not have a very strong family history of diabetes, the patient does not have obesity and those kind of factors, probably once they finish the chemotherapy cycles, they may come back to normal and the sugars may remain normal. But sometimes you may have unmasking of diabetes and they may, at least they may remain pre-diabetic. Plus the other issue is that some of the drugs which are used, chemotherapeutic agents which are used per se also can increase the risk of diabetes. You have a lot of these newer drugs like the immune checkpoint inhibitors, which can increase the risk of diabetes. So those things also we have to probably keep in mind when we are following up these patients on an OPD basis.
Yeah. Thank you, Dr. Anish.
Vaishali, what we need to keep in mind is that immune checkpoint inhibitors can also cause type 1 diabetes. So the patient actually may come back to you with DK. We face this situation not realizing, not doing a urine ketones at that point of time, not realizing this patient is actually in DK because it was assumed that it was the chemotherapy which is causing the vomiting for the patient and kept on treating that, not realizing that a patient is actually in DK.
Yes, Shaila, that's why we had Dr. Apar speaking on the diabetes caused by anti-cancer agents. So I think that's an irrelevant point because we are seeing more and more usage of immune checkpoint inhibitors. So we'll be seeing more of diabetes caused by these drugs also. There's one question from Dr. Chetan to either of the two can answer this. Will it be a good idea to check HbA1c once in 3 months even for cancer patients like we do it for our routine diabetic patients? So Anish,
if the patient is already a diabetic, yes, it would be a very good idea because what we have to keep in mind is that when a patient is undergoing chemotherapy and those cycles are more frequent, he or she may not be able to have a very disciplined lifestyle. They may not be able to go for regular walks. They may not be able to follow a regular, timely food meal pattern. And the sugars may go up and down. The risk of hypos may be there because they're anorectic because of the chemotherapeutic agents and probably cancer per se. And at the other end of the spectrum, certain drugs like steroids and some of these drugs which we talked about can cause hyperglycemia. So what happens is that you'll have a lot of fluctuations. So if you do HbA1c levels and see that it's maintained between 7 to 7.5, even if there are periods when the sugars are shot up, at least it gives us that kind of confidence that, okay, things are on the right track. So I think it's a very good idea to do it at least once in 3 months.
Yes, Dr. Chetan, you had some point to... Yeah.
Just an addition that Dr. Anish mentioned that dexamethasone is given once every 3 weeks. We have some protocols where we have this chemotherapy given weekly. And every week, the patient receives 8 to 12 milligrams of dexamethasone, which I believe is fairly high.
Very high.
And these patients are taken, these are usually small doses of chemotherapy, but because of the potential to produce anaphylactic reactions, we give steroids as a pre-medication. So these patients normally don't come to us with chemotherapy related problem. So we will never be checking them very religiously. So maybe in these patients, we need to check their HbA1c once in a while. They have never, if somebody is not a diabetic, he or she is never going to check sugars or HbA1c. But if somebody is going to receive 8 or 12 milligrams of DEXA every week, then I think there is a case for doing HbA1c once in a while, at least once during that 12 weeks course. We can do it sometime, maybe midway, and assess whether a person is going. We have alternatives. So it's not that we have to give this same medication 12 weeks. If the patient has developed diabetes, we can change. Already there are so many other options available. So that was an interesting point, that DEXA can produce sugars, higher sugars for almost 2 to 3 days. So that is something which we tend to overlook.
I think, Shaila, it's time for guidelines in diabetic guidelines in oncology. So I think there's a lot of education to be happening on this ground. So we will hear more eventually. Yes, Shaila, please.
Vaishali, if I can add over here, Chetan, what I would also suggest is along with the HbA1c, do an SMBG when your patient comes to you. At least do a blood sugar random, because sometimes an HbA1c may not be a very, very accurate reflector. You know what Anish said, you may have a lot of hyper. But if you look at an HbA1c, for example, you may see an HbA1c of 7, for example, and you may actually be having a patient with hyper as well as hypo, but the HbA1c looks absolutely fine. So I think what can be added as part of your regimen is that either when your patient is being discharged or at admission, we do one SMBG, which on the glucometer, which would give you a relatively fair idea as to how your patient is behaving biochemically.
One important point I think Shaila mentioned is there's an equal risk of hypoglycemia. So when the 4th day happens, that is the time when the DEXA effect goes off and the sugars start falling, and the patient is actually being prescribed XYZ amount of insulin if the patient continues, irrespective of monitoring. So monitoring in the first week at discharge is very important. That is what I think this whole discussion highlights. So Chetan, I wanted to ask you that can diabetes come as the primary manifestation of cancer? Can it come as the first manifestation of any cancer?
That is rare. That is rare because most of these patients will have some diabetes related problems. Also, it does happen sometimes that a person has been detected to have cancer and then he has undergone a whole battery of tests and somebody also does a blood sugar which is high. So that is a possibility. The other possibility is, of course, if it is stress and a lot of things happening, the patient is extremely upset, and a little bit of stress, especially somebody who has been obese, who has a potential to develop diabetes because family history or something like that, then these patients can come with simultaneous presentation of diabetes and cancer. But diabetes coming as a
what about pancreatic cancers coming with diabetes?
Very rare, very rare, very rare.
Okay. So it is mainly the routine screening that gives rise to the awareness of diabetes. That is a coincident diabetes with malignancy. Okay, so Dr. Shaila, I just wanted to know that if you have IPD patients with cancer with a lot of vomiting, nausea, anorexia, how do you go about with managing their diabetes then? Because you're not ensuring a proper oral intake. They may be dehydrated. They may not tolerate medicine. So in IPD or OPD scenario, both. So how do you treat these patients when they have GI side effects or GI malignancies? So this is to both of you all, Anish and Shaila.
Vaishali, these patients require very individualized care. There will, to be honest, no one rule fits all. You would have to take it, sometimes you have to take it not only from day-to-day basis, sometimes you take it from hourly to hourly basis. It can be that critical. So it would all depend upon intensive monitoring, very, very close care for these patients, and closely sort of, designing therapy according to what the patient's requirements at that point of time are. For example, if the patient is not having adequate oral intake, then you would most probably start these patients on IV fluids. Sometimes you may need to put these patients after 2 or 3 days on RT feeds. And again, over there, you will have to, adjust your medication according to your patient's requirements. But practically in an IPD setup, what works best is insulin. You use either a combination of short-acting or long-acting insulin depending upon your patient's requirements. But as an anti-diabetic drug, what I prefer in an IPD setup is definitely insulin. I do not prefer using any OHAs though, because although we say you can, some of the data says you can use metformin, I would be very uncomfortable using metformin. Any patient who's anorectic or is having any kind of nausea, using any other OHA for that for that time.
Dr. Anish, what about you? Suppose a patient has been on OHA, well managed, well controlled, and gets admitted for chemotherapy. What do you advise? Would you stop the OHA? Would you continue? And eventually at discharge, what's your take on OHAs? Whether the oral agents should be used and which ones, if any?
If the patient is getting admitted for one cycle of chemo, probably, as Dr. Shella rightly said, if you have given them prednisolone in the morning, the sugars are going to shoot up post-lunch and pre-dinners. So probably you can cover up that particular meal with an insulin for that one day in the hospital. And post-discharge, the patient goes back home, the effect of steroids would have gone away, the patient can go back on their oral drugs. That's the easiest way of doing things. Now, the problem comes when these patients are, when the sugars are really high. What I would suggest, what I personally believe is that for somebody whose sugars levels are up to 150, 180, probably you can still manage the oral drugs. But in the inpatient setting, I think I agree with Shala that insulin would be the best option. I'm talking about the OP setting. Somebody whose sugar levels are hovering around 150, 180, maybe oral drugs would be fairly okay. I would continue them. I would probably step up the oral drugs if the sugars are going above 180, maybe up to 250. But if the sugars are persistent above 250, 260, I think I will ask the patient that for a few days, it's a better idea to start insulin, maybe as an add-on to oral drugs, or maybe switch over to insulin altogether. But probably as an add-on would be good enough. So that's what I would do on an OP setting. But inpatient setting, I think I agree with Dr. Shella that insulin is the best option, the safest option, and it gives you that ability to titrate. You can move up, you can move down, which is not possible with an oral drug.
Yeah, I agree with both of you all. And I think that any sugar above 300, ketones also should be monitored because they are highly prone for ketosis. And as Shaila rightly mentioned, some do produce even the insulin requiring type of diabetes. So insulin dependent type of diabetes. So Shaila, just for the benefit of the audience, because we have a mixed audience, can you just mention the short-acting analogs, which insulin analogs, because not every specialty would know about it. So maybe they will know what are the short-acting insulin analogs available in the market, not the brand, but the type of the pharmacogenomic names.
We have the short-acting insulin analogs. We have insulin Apar. We have insulin, we have Humolog, and we also have in the other short-acting insulin analogs, we also have the glulicine, and we have the ultra short-acting insulin analog also, which is your Fiasp.
Yeah. So we have this, fortunately, we have a good array of short-acting insulin analogs. And I'm sure that physicians and diabetologists managing oncology patients will soon get versed with these molecules as they see more of diabetic patients with cancer. So Dr. Chetan, actually this question is to all of you. I want view from all of you as to what is the lifestyle and diet management for a cancer patient, because we can't be very hard to them. We can't be very blunt to them in terms of strictness of diet and exercise. So how do you really manage the lifestyle of a diabetic patient with cancer?
So there is some data to say that there are some medications which have already been discussed, like immune checkpoint inhibitors or some of the tyrosine kinase inhibitors, where these drugs themselves are known to produce hyperglycemia. When I'm starting my patients on these drugs, I tell them to go easy on the sugars. They should not consume free sugars. They should not eat overtly sweet stuffs or a lot of sweets. Once in a while is okay, but not excess sweets should be strictly avoided. That is one thing. Second thing is trying to stick to a healthier diet and not binge on stuff especially when they are okay. When they are not feeling like eating, then these people tend to have weird cravings and they eat some things. that is the time when you have to adjust your anti-diabetics. There is not much choice, because that time the patient eating something is more important than the quality of foods. But when the patient has recovered from the nausea or vomiting episode, then we try to get them to eat what they have been usually eating for the past several days, which is their normal diet, so that their sugars don't go very haywire. Now, exercise is a little difficult to convince a patient to do exercise, because these patients have some good days, some bad days. On good days, they feel like doing everything. They feel like exercising. They even feel like going to their work. But on bad days, they don't want to get out of bed. So that becomes a little bit of a problem, because during the same chemotherapy cycle, some days their sugars are going to be low. Some days their sugar is going to be high. So that is a challenging problem. But I don't see any clear-cut answer to that. There is no one solution which is going to fit all these patients. Some of my patients have gone on the treadmill the very next day of their surgery, and some of my patients have not left their house in the last 6 months out of fear. So it is very, very individualized. We decide, we have a word with their treating diabetologists. I also make up, it is one of my these things that instructions that whenever I start a patient on chemotherapy, I write a letter to the treating diabetologist that these are the medicines which I'm going to start, and you may have to adjust your anti-diabetics accordingly, because the steroid schedule, he may not know the steroid schedule. If the diabetologist is not in the same hospital, he may not know what treatment is being given to the patient. So it is a good idea to give a letter to the treating doctor that these are the changes which are going to happen. Please adjust your medications accordingly. It helps.
Thank you.
Shaila, you any take on this? Shaila, Anish?
Chetan has very well put across the role of collaboration, where the onco and the treating physician need to be on the same page. Thanks for that, Chetan. And I totally agree that we need to individualize therapy, what Chetan is saying. And I think over here, Vaishali, the role of monitoring plays a very important role. Because if your patients are able to monitor closely what is happening, whether they are going into, for example, hypoglycemia or whether they're going to hyperglycemia. For example, because they're not eating well, they tend to eat a lot of high calorie food, which is easily digestible, resulting in a lot of hyperglycemia. Sometimes sugars that can really go high. And though I totally agree with Chetan, we need to understand diabetic patients are generally, these patients are also elderly patients with a lot of other comorbidities, a lot of other medications, a lot of other complications happening at the same point of time, which we need to keep in mind when we are advising therapy for these patients. For example, they may also have hypertension, they may have IHD, they may be having peripheral neuropathy. So it's a very, very complex situation to really be handling. It is not as simple as a patient only having diabetes and malignancy. There's so much more to this entire situation, and that's again where I say it would require a team approach. Maybe we can have a nutritionist involved, maybe sometimes just having a helpline where these patients can connect and because talk about what is the problem can also make a very big difference to their care.
Anish, your take?
I think I agree with both the panelists that these things need to be followed. I just have one point on which I personally believe that we need to stress more. That is SMVG monitoring. Dr. Shaila rightly spoke about it. These patients, I encourage most of these patients to buy glucometer and check sugars, if not 3-4 times a day, at least once in a day or once in 2 days. I tell them to, do it in a staggered manner. Check sometimes in the morning, sometimes in the afternoon, sometimes in the evening, and you chart your sugars so that you have an idea of where things are going wrong, and then you can address that. That is something which probably helps a lot of patients, and they get that confidence that, okay, the sugar levels are fine, there's nothing, things are okay. So it gives them that additional motivation to do things right. And whatever Dr. Chetan said is absolutely right, that we cannot be so strict with their diet and exercise. We have to go along with the flow.
Yeah, I agree with all of you, and we do give them a liberty of keeping their sugars below 200 so that they have a sense of well-being also, and they do not go into severe hypoglycemia or severe hypoglycemia both. So I think Chetan has one comment. It is written that WhatsApp diet should be strictly forbidden. So yes.
So the issue is a lot of patients have this WhatsApp forward saying that if you stay away from sugar, the cancer gets controlled. That is a totally false belief, and cancer is not going to be considerate that if you stop eating sugar, it's going to starve. I tell my patients that a cancer is going to break down your muscles and then feed itself. So keeping people away from all kinds of sugars also doesn't make sense. Having some kind of pleasant diet is also important from their quality of life point of view. It also keeps their morale up. So once in a while, they can have a little bit of sugar. It's not that they have to have complete bland, but these WhatsApp forwards of drinking warm coconut water or eating lemon peels, I don't think these have any science behind it. And it should be, they should be told that these are completely false and have no sense in them at all.
Yeah, I think there's a need for a liaison educator, a dietitian in this whole team. So managing diabetes in an oncology patient itself is a teamwork, and putting it in the right sense, I think the patient is likely to have a better quality of life and a better improvement in their survival rates. So I think we had a wonderful discussion, and the time has just flown by. I just before we close up with the session, I want each one of you to give a take home or a key message on this World Diabetes Day, especially in relation to oncology and diabetes. So Shaila, you first, then Anish, and then Chetan.
I think collaboration, education, and a high index of suspicion are the best ways for us to manage diabetes in a patient who's either diagnosed with cancer and is going to undergo therapy with cancer, so that we are able to understand the interaction between both these disease processes.
I think the most important thing is that the patients are made aware of the fact that the sugars would vary in the course of treatment of cancer, because a lot of patients probably don't understand that the sugars will go up because of the agents which are used for treatment. And if they're made aware of this, probably they'll take a little extra care of their diabetes.
Chetan.
In my opinion, cancer patients are subjected to 3 S. One is stress, other is steroids, and third are sensational therapies. And all of these 3 can produce high sugars. That's the 4th S. So we need to be open to the idea that the present problem may not be related to his chemotherapy, but he may be suffering from a newly detected diabetes. So that has to be checked, and we need to be a little more cautious, especially now that our patients are getting older and getting these wonderful new therapies, which by themselves are known to produce hyperglycemia. So we need to probably add SMBG to the host of tests which we normally prescribe to our patients.
I think that's a good mnemonic to take home today, the S's. So it was a lovely discussion, and thank you all for being here, sparing your valuable time on this World Diabetes Day. And I'm sure that there will be a separate outlook towards patients with diabetes and oncology. And this seminar is going to definitely help educate all our audiences on this aspect. So thank you all for being here. Thanks a lot.
Thank you.
Thanks for calling us, Vaishali.
Thank you.
And thanks to Dr. Thank you.
Thank you so much, Dr. Sheikh, Dr. Deshmukh, Dr. Behel, Dr. Ganti, and Dr. Vaishali for your time and efforts you took to share your thoughts and experiences with the DocPlexus community on the occasion of World Diabetes Day. A big thank you to all our dear audience for their kind listening. Hoping this session would give you new insights in treatment of diabetes. Stay tuned for our upcoming session on surgeries for diabetes treatment today at 5 p.m. Until then, take care and happy DocPlexing.